I'm Arva.
I'm Gracie.
And I'm Yuritsa.
And you're watching SLPeas podcast, episode 9.
Yay! 9! It's extra fun.
We made it to 9 episodes.
Almost at our big number 10 to finish off.
Don't you love how at each episode we go, we made it? Like, we're surprised that we're still going.
I'm very surprised because it's been a journey. We just kind of woke up one day and decided to do a podcast, and we've actually, did it.
We have, and it's been a really wonderful experience for all three of us, and to be able to have different guests on the episode. And it's so nice to hear from you guys about what you think and what you wish you were seeing. So thank you so much for the feedback. Today's episode is all about our clinical cases. So we're going to talk about different cases that we experienced in our externships or in clinic in grad school, and how we kind of handled those cases with the treatment that we provided or the evaluations that we conducted. And we hope that you guys find some knowledge in these cases and some help if you find or have a case similar to this one right now. All right, so we're going to start off with Gracie. Gracie, tell us about your clinical case.
Concern me? Oh my gosh. So my case was when I was working at a preschool, which was for the deaf and hard of hearing. So all of my kids were, I think, 2 to 4 years old. They all were language delayed and they had some sort of assistive technology. So the kid that I want to talk about today had cochlear implants, bilateral sensory neural hearing loss. And he had been wearing them for 2 years. And as we started treating him more and more, and we started realizing his speech patterns were very different than all the other children that we were seeing, we started considering that he had CAS, or childhood apraxia of speech, which was really, really difficult to diagnose because we kept chalking up all of the distortions to the hearing loss. And it wasn't until really we did some testing, figuring things out. We gave him Goldman-Fristow, PLS, expressive language test, receptive language test, and we really started paying attention to how he called people and the words that he said definitively. Like it was like my name to him was BB. My name is Grace. But it was always BB. My supervisor's name, I think he called her her name began with an A. I don't want to give away any personal information, but name began with an A. He was like, and so everyone kind of had their own little way of being called. We were like, that's not normal because he can hear what we're saying. And if I say, oh, where's Grace? He knew, he was listening, he understood, but I was coming out as BB. So we started targeting different speech babbles, which was what we were calling them, which were almost nonsense words, but we were helping him figure out the difference between 1 to 2 syllables. Was he able to distinguish, and then was he able to imitate them? We would alternate speech babbles, so we would go B, 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 and have him go B, B, B. We had a little, almost like a board, and it had circles on it, and he would touch each one. So this way he kind of understood what we wanted. Because sometimes he got frustrated, and he would go, beep, 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 and it would become a funny joke. So we needed to remind him, no, just 3, beep, beep, beep. And then to mix it up, kind of, because no word really sounds like that, we would do bee, boo, ba, ba, and we went through all the vowels with the same consonant. And then we would mix up the consonant, and it was really working. So then we started doing it with names. So we got all of the pictures of the kids in his classroom, and we would play games with them. We would put the pictures on the table and say, oh, let's give, I don't know, I'm going to make up a name. Let's give Jeffrey some food, and let's give Megan some food. And he would use a 2-syllable babble for their name. And it was great. And he started using them not only in the sessions, but in the classrooms. And that was one of the great part about this preschool, was that it was so small that I often got to not only pull out, but push in, sometimes twice in a day, because I had a free schedule, and I'd be like, you know what, I'm just going to go and sit with them and see what's going on. And I would hear them using things in the classroom, and I was like, you nailed it. Like, that was it. And it was just so wonderful to see this kid just grow and learn with this thing that we researched in the back of the clinic room. It was us, my supervisor, and her supervisor were trying to figure out, what do we do with this kid? But it was just so nice to see how far he came along. So I probably, that makes me want to go check up on him. I think I'm going to call my supervisor and see how he's doing. I'm wondering if he's got everybody in the whole school's names down and all the words. But he was a fun kid. I kind of miss him now. But yeah.
Come across any challenges when treating him?
Oh yeah. It was just so frustrating because you saw him trying. He was such a sweet kid and so well mannered, and he didn't want to make anybody like displeased or upset. But every time we were like, oh, that wasn't it, he would just kind of get bummed out. So to fix that, we started doing just the beginning of the session. So it would be like the first 10 minutes, maybe less. We would go through all the sounds, and then that was it. That was done. All done. That was part of the routine. That was our beginning, and we're all done. Work is over, and now we can play. And you'd say it like that, so this way it didn't seem like the rest of it was work too, because of course there was more that we were going to do. But the work was over. But yeah, that I think that was the hardest part, just because, especially with childhood apraxia of speech, it's not, I think all speech disorders, it's not anything you can really help, but he's watching, he's trying, and you see this groping behavior, and he wants to do what you're doing, and the pieces just aren't coming together, and that frustration was upsetting, especially because he's a little kid. But the resilience was incredible. He was able to just push through, and that was one of the best speech therapy I think I've had so far. It just made me feel like this is what it's for.
Right. So he also had a cochlear implant as well.
Mm-hmm. He had it since he was 2 years old. So on top of being language delayed, once he got the language, no one understood it. It was so unfortunate. But that's a good thing where testing kind of came in handy. We're like, you're definitely understanding, you're definitely hearing all the sounds. You know the difference between these two words, and okay. So now when I ask you to say them, why aren't they coming out that way? And when you see my lips, why aren't you doing what I go buh, 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 and you can't. That's not an auditory thing. That's
like his processing of what he's seeing. It's hard for him to process that, and then processing to execute those movements.
Yes. So, a very interesting case.
So what does it take, like what does a speech pathologist do when they're seeing a child who has a cochlear implant? Like, is not really sure what that process is like.
They're a very, very fun bunch of kids, because it's amazing how somebody so young has such a high grasp of that kind of technology. Like, you come in and you're like, are your implants working? And they know to take them off, take them on, and they go, yep. Or they look for the light and they go, yep. Or if they have an FM attached, sometimes they'll let you know, like, I can still hear my teacher. And they're like, oh, thank you. Like, they're just so many cute things that you're not expecting from like a 2 to 3 year old. And you're like, thank you, I'm figuring out this device. And you're like, whoops, battery died. And I'm like, thank you, bud. But the number one thing you should do is do a listening check. So that's kind of like using all of call them ling sounds. It's like ba, ka, ta, ha, and then like the vowels that go with them. And you cover your mouth and you have them repeat them. And when so they can't see what you're doing after you check that the devices are working. So that was the whole, is your hearing aid working? Yes. And then you check their sounds. And if they can't answer them back, give them another try sitting on another side and seeing if one's better than the other. If a kid's implant is out, make sure you sit on the side with the best ear. I know that sounds silly, but I did it once or twice where I was just used to sitting in the same seat all day, and the kid came in and I was like, oh, you're not hearing me on that side. No wonder we're having a hard time today. And then you have to move around. So there are little nuances that you don't realize, but
Yeah.
with the exception of the hearing loss, you also don't have any of the other typical obstacles, because typically they're otherwise developing normally. So they are receptively better. They're expressively like maybe a year or two younger, just because they have the delay of being introduced to sounds and language, but they're typically no behaviors, not so much of extra needs that come with a lot of speech diagnoses. And some of them do, like my little man that I talked about before, we found out he had a co-occurring disorder, but not all of them are like that. So sometimes it's just a matter of just catching them up to speed. And then once they have their devices, they know them better than anyone else. It's just such a fun population.
Yeah, like I've never experienced that. So even, especially us going into the field, like we have a lot to learn, even though we know a lot, but there's still so much to experience. So I'm glad you like explained it like that, because now that all of that makes sense and it ties in with the stuff that we've learned in class. So thank you.
Right. No problem.
Okay, that was great, Gracie. Thank you for sharing. Now let's move on to Yuritsa. Let's hear about your clinical case, girl.
It's my turn. Okay. So I want to talk about an adult case that I had in grad school. I was in our university clinic. This adult client for me was like life-changing, because it made me see how much I actually enjoy working with adults, because I know I can work with kids. I've been around kids for a long time. Growing up, I was always around kids, but this made me see that I really like doing adult treatment. So a little bit about her. She was diagnosed with a rare neurological disease, which resulted in non-fluent aphasia. And so I had never really worked with someone like this for a good amount of time. So her goals were improving her receptive language skills, improve her expressive language skills in terms of conversation, improving her reading comprehension, and even her written expression. So the activities that I chose to work with her, it's so different, because when you're with an adult, like you could just be very straightforward. Like, what would you like to do? What would you like to work on? Like, what can we do that's enjoyable, that we can still make it challenging? So we would watch like really funny commercials and then like try to interpret them after, or like ask questions as to like, do we think that they were selling their product well enough, and kind of just like made it super fun in that way. I loved doing that. We did that first because that was my favorite part. And then we also looked at like travel articles, like food articles. We did like spontaneous conversations about her family, her week, what she was planning on doing. And then we did some drill practice to improve like identifying articles and like correcting her written expression. So that variability in therapy like was so enjoyable for me, but also the client. Like I really benefited from that positive reinforcement, because we used to debrief with her husband and we could just see the progress from the week prior, how well she was doing, when we were both like attending to the same thing, truly enjoying what we were doing, and like just connecting. So I learned that even though learning about language, learning about non-fluent aphasia, all that stuff came from my supervisor as well, because she's a queen. And her advice really gave me a lot of confidence in choosing therapy materials and choosing what activities to do. But the main thing that I learned is that every client has their own learning style. It showed me how rapport building is like so crucial, because that helped me prepare materials that I knew she would enjoy. And then I already knew that she was already more motivated and more attentive to do challenging things with her. And she wasn't hesitant to do it, because she knew I wasn't going to, tell her, no, everything is wrong, and like completely correct it. Like we worked through it. All activities, they were flexible and they were challenging, so that I could find her strengths and her weaknesses. And I just learned that like hard work pays off, on both ends. So like if you're really doing the hard work with your client and really wanting to do better, and you look at your resources, you get advice from friends and your supervisors, like all of that also equals a good therapy session and your client working through their goals.
That was great. And even though I'm a little biased because I know who you're talking about, and she was probably the sweetest human being to exist, do you think that, incorporating her interests and her passions into therapy was really beneficial for her?
I think for her it is. You like understand that some kids, when you put their like most loved things, then they get too distracted and they can't focus on their work. But it's so different with an adult because you can really do enjoyable things that both of you can discuss and connect on, and it would really benefit them because they know they're there to work on their language. They know they're there to do the work, So I think and that's what that taught me about clients, that not every case will be as like wonderful as her in terms of like being on the same page and knowing each other's learning styles, and in that way it just clicked with me and her. But that just taught me, I know that every client has their own way that they exist in life and their own enjoyable things, and like my job is to find that, to get them to work through their language or their speech or whatever it is that they need to work on.
Do you think that she was a textbook case of non-fluent aphasia?
So that was the challenge, because she actually wasn't the textbook case of non-fluent aphasia. There was always debates on like, does she have fluent aphasia? Does she have non-fluent? Because her written expression was so much better than her verbal expression. And like she would just like, once she got into like her like groove, she would just come out with all these like wonderful sentences, expand her utterances, and like it was shocking. So for her it was tough because she was also I can't remember her background, but I know she was like educated, she loved to read, she loved to write, like all these different things. So she was so highly motivated in that way. So her case was actually really challenging because her strengths and her weaknesses varied so differently.
Wow. How was her reading?
Her reading was also a lot better than like her auditory comprehension. So like her reading comprehension was a lot better than auditory, and her written was a lot better than verbal.
Interesting.
She was such a fun, I don't want to say a fun case, but
interesting case,
because you have to piece so many parts of like a case like hers. And I think that it's such a rewarding experience to work with someone who has aphasia. The progress you see, like even the smallest things, like are big victories.
I think in our profession, it's okay to say you have a fun case, because if we don't find it enjoyable, nobody will. Right? We enjoy putting the pieces together and having a fun time doing it. Otherwise, we get burned out, and it's okay to have fun.
Yeah. I just think of Brooke when I say that, because when she was on our episode, she was like, I don't want to say I love these cases, that I don't want people coming in with TBI. But the reality of it is, if there's a disorder or some kind of neurological deficit that you have to work with, that's one of my favorites to work with.
Yeah, I love that. Again, I love aphasia, but I wish people didn't have aphasia, but I love working with people with aphasia. So.
Exactly.
Yeah.
It's very fascinating.
Yeah.
It's one of those things that even people not in the profession want to know about, especially because it afflicts so many people. Everyone has someone that they can relate to, like, oh, I think my grandma had that. And you're like, yeah, probably. And it's exciting that they want to hear about it. And so everyone's fascinated by, I think, the brain in general, but just kind of how it changes. I think it's always interesting.
Definitely.
Yeah. So Arva, let us know what your case is about.
Mm-hmm.
So I'm going to take it home with some feeding.
Not surprised.
At the pure request of me. And if you guys love listening to our cases, we'd love to have another episode of clinical cases that are primarily adults, so you let us know. But I'm going to talk about some feeding first. I was in a very, very special place my last semester of grad school, and I was in a feeding program, a feeding disorders program. So it was a very comprehensive program, and we had two types of individuals who came in. We had someone who would come in once or twice a week for 45-minute sessions, or we had someone who came in 4 sessions a day, 5 times a week. So when I was there, I'd have practically one client over the course of 4 weeks, 20 times a week. Or not me 20 times a week because I was only there 3 days, but 4 days, but you get the gist.
They would be seen.
Yeah, so we call those types of cases day patient cases because you're almost like an inpatient at the facility, but you're not living there. You're coming in from 8:30 in the morning and you're leaving around 2. So I saw them for all their meals practically, except for dinner.
Wow.
Yeah. And to get into that program, you have to go through an evaluation, which is usually done by the SLP who's on the case, the registered dietitian, the pediatric nurse practitioner, and the behavioral analyst. So chances were, I don't think I came across it that often, but some of the kids that I evaluated actually did enter the program, or because there was such a long wait list at the program, I'd see someone who was evaluated a year ago, and sometimes the feeding has gotten worse, or sometimes it's progressed a little bit. So different kinds of people I got to see. But the best thing about having so many cases with one client is that you really get to work fast and quick, and your baselines are started in the beginning, and by the time that treatment's over, usually you've hit like 10 goals, and sometimes you don't, so that's okay. But one of the best parts of seeing someone so many times a week is that you're really progressing, even if it's slowly. So one kid I had was about 2 or 3 years old, and he came in with a feeding tube. He was primarily dependent on feeding tube, so he was getting 4 feeds a day to, sustain his nutrition and hydration. His diagnosis behind the feeding tube is that he had a genetic mutation that actually caused him to get really ill if he consumed anything more than 6 grams of fat a day. I don't remember the name of the genetic mutation, so I don't want to sit here and pretend I do, but I do want to say that it was a genetic mutation that can be extremely dangerous. So it was a lot of work for the SLP, my supervisor, myself, as well as working with the dietitian and the pediatric nurse practitioner, because everything that we fed him had to be within his diet, and we couldn't go over those grams of fat. So it had to be like a very careful and precise treatment program for him. He was completely nonverbal. He didn't even babble, if I remember correctly. And he was, like I said before, completely tube dependent. And prior to admission, his parents often tried to, practice oral intake with him, but his response of liquids and purees was complete refusal, absolutely refusal, and his response was to vomit. Mom would give him a drink, vomit. Dad would give him a puree spoon, vomit. So when I got there, when I started my externship there, he had already been seen, I think, for 2 weeks at that point. So I hadn't seen him from the very beginning, but from what my supervisor told me, that was his response, was usually vomiting. Parents were hopeful, however, to increase oral intake in order to wean tube feeding. And I don't know if anyone is, really in tune with feeding disorders in the speech population. Scratch that. I don't know how in tune everyone is to SLPs in the feeding population, but our job is not to wean tube feeds. That's not within our scope of practice. However, what we were trying to do is increase oral intake, and by increasing oral intake, if we had got enough to sustain him, we were able to remove 1 tube feed with the permission of the registered dietitian and the pediatric nurse practitioner. So we were trying to get down from 4 tube feeds a day to 3 tube feeds and 1 oral meal. That was just our goal. Slow and, steady wins the race. So in session, we'd have to measure all the food prior to beginning the session. And because he was someone who frequently vomited, I'd have to also measure the bib and a little towel that we usually place to clean up the throw up. And I'd measure everything before the session, and I'd measure everything after, because if he did vomit, I had to measure how much he actually ate. And that would determine if we changed his rate of feeding. So the feeding tube was given to him at a different rate if he had eaten more food. Or if we had a really successful day, after our 4 sessions, he would have enough to feel 1 meal. He'd be able to not have another feeding tube meal at the end of the day. So it was complex in the sense that you had to be really careful because of everything that he had going for him. but it was really interesting because I had never worked with someone with feeding tubes before. Each session usually began with oral motor exercises. So we did extraoral and intraoral. We'd start from his forehead and get all the way into his mouth. And the importance of doing these oral motor exercises was because he was so he would refuse so much the food and the drink and even just the utensils. You had to like gain his trust and kind of reduce his hypersensitivity to being touched and fed. So we had to do that every single session. So 4 times a day, I was constantly massaging his face, going into his mouth, using a chewy tube. Even though he wasn't working on chewing at that point because we still had to just get him to eat, period, we were trying to develop those skills because at that age you should be chewing. Use purees. So there'd be purees that were cooked at home or we would puree in the facility. However, his mom was really great about making different variety purees that were like within their cultural norms and stuff. So that was great. He was able to eat foods that mom made at home. And we also did Pediasure. And the Pediasure was great because Pediasure has that caloric intake that he needs, but also doesn't go over what he is supposed to consume. So that was great for our liquids. And what we worked on with him was contingent reinforcement. So in order for him to eat or drink, we had to reward him with something. It was the only way to progress in the session. So it was 2 bites and 1 sip, and then you get cocoa melon, and that was like our routine. So he'd get 2 bites of puree, and I would increase the bowl size very slowly. So I'd begin with literally a coating of the puree, not even half of the tip of the spoon, very little, put in his mouth. He'd have to eat it, and he'd have to not react negatively to it. I'd have to watch his facial expressions. One of his favorite things to do is go like this after every single bite or drink. Even though it was not on his lips, he was like this little manly man who was like every time. So we'd have to try to hold his hand down a little bit or like make it in a way that it wasn't reinforcing like no, but that he had to learn that he doesn't have to wipe his mouth after every time something goes in it. So we did that, and then he would have 1 sip of Pediasure, and the sip of the Pediasure was provided through a honey bear, which was helping him develop his sucking skills, but at that point we were still squeezing the bear for him. He did, however, improve to the point where he was squeezing it himself. So after those exercises, his oral hypersensitivity kind of decreased, and he was able to increase acceptance of foods and drinks, so that was great. And as we monitored his GI systems, because as I said, the genetic mutation with all the fat and everything, so one of the things that he always did in a session is he used to show signs and symptoms of like some kind of GI disturbance. So one of the signs that we used to look for was his arching. He'd arch over the high chair, and that would be a sign that he's like getting too full or that he's ready to throw up. So the moment that we saw that, it was like, okay, and now we decrease bolus size. So he was really reactive to people's behaviors in the sessions. And I say that because one time his dad walked in and he was eating and drinking. He looked like he was getting a little bit too full. Like I had seen the signs develop a little bit, but I wasn't 100% sure it was going to happen. Dad walks in, he looks at his dad, vomits. And this was probably my first day with him or second day with him. So I was like, what a way to meet a kid. But he vomited, and, my supervisor and I cleaned it and reacted so simply. Cleans it up, threw it in the garbage. I weighed it first, threw it in the garbage, sat back down, and started feeding him again. Act like nothing happened. And the best thing about that is he then did not react anymore. He was like, man, no one's paying attention to me, even though I just threw up all over the floor. All right, I'll just keep eating. And, that was just what we needed to do, was kind of ignore the vomiting and just continue feeding. Never force feeding, but it was the point where you couldn't, reinforce his negative behaviors, because then what's the point of coming to therapy for feeding if you're not reinforcing the positive ones? So we looked for signs and symptoms. Like I said, arching his back. He'd also burp. And if his burps were really long or heavy or very smelly in a sense, something's going on there. We should either slow it down or kind of back it up. And we never were in a mood that we had to feed him the whole bowl, but as much as he could eat was great. And we usually aimed for a certain amount of ounces or grams, but sometimes we met them, sometimes we didn't, and that was okay. His goals did progress after we had met with the pediatric nurse practitioner, the registered dietitian, talked to mom and dad, and saw him progress over the couple of weeks that he was there. So he actually went to a point where he was increasing acceptance of oral intake, and we were able to remove 1 tube feed a day. So that was a huge win. And not only were we able to do that, but we were able to increase his feeding tube rate, which is a big win, because when they used to increase it at home or when they were told to by the doctor, he would vomit, even if it was a night feed. He'd vomit when he was sleeping, or he'd wake up and he'd vomit because it was so uncomfortable, or, any of those cases. And what I learned from working with him is that when you have a kid with GI symptoms or when you have a kid with medical complexities that you're not familiar with or out of your scope, you need to do continuous interdisciplinary assessment and treatment. I learned so much about different food intakes and liquid intakes that you could do with kids like him. So what can you feed someone like him? How can you do without pushing him? How do you react to negative behaviors like someone vomiting as response? Like, these are all things I hadn't seen or heard before, or we had heard about before, but it's different when you're in the moment. So just getting him to like have one less tube feed a day, so he'd only be fed 3 times a day by tube feed, and one time he had a whole oral meal with his mom. Like, I think mom was like almost ready to cry at that point, because they went from a place where they didn't think that was possible. How will I ever be able to feed him? And it was a really emotional experience. My supervisor was absolutely amazing, and at this point in my experience, I was still not like independent yet. So a lot of it was working with my supervisor and kind of learning the ropes from her before I did become independent later on. But it was absolutely amazing to see. Like, I don't remember ever thinking, how does she do this every day? I just was very much like hypnotized by how you handle cases like this, and how like effortlessly she knew how to communicate, the findings with the parents, how she knew how to communicate with different team members. And I just think feeding treatment is amazing, but you need to see what is done at this facility to understand the lengths that some people have to take to get their kids to have a nice meal. So I think it was a really good experience for me.
I had a bunch of questions, but you answered them along the way. Tracy?
So I did have one question. You mentioned before how you gave him a facial massage. Would you mind elaborating a little bit more as to why you did that? Because I think that would be really helpful to know for all of our people who are a little bit less familiar with feeding, because I know I always go to Arva for feeding tips. She's like the feeding lady, feeding guru, always come to her. So I think that is a very interesting tidbit that I don't think people would think of.
So we did the oral motor exercises before our sessions, and we did that because we needed to awaken his system and to decrease his oral hypersensitivity. So the only way we were able to do that was to go extra-orally and then move in intra-orally. By gaining his acceptance on the outside of his face, of his mouth, we were able to like slowly move into the inside of his mouth, as far as doing tongue rolls with a Nook brush and using a Z-Vibe. So all of that was for him and to benefit him and increasing his acceptance. I think it works for a lot of kids, and I highly recommend it to anyone who's doing feeding on anyone who has increased hypersensitivity and low tone. But of course, everything depends on how your client presents. So look at the research as well.
Thank you. That's super helpful. And also might have just solved a problem I'm having with the kid. So thank you.
No problem.
Well, thank you guys for sharing your amazing cases.
And thank you too.
Oh, it was a lot of fun, actually.
I mean, I know we're still in the early days, they're at this point our graduate clients, but I don't know, I feel like you're not going to forget a client, or at least one that you saw so consistently. Like, I think acute care is a little different. You see them for a few minutes and then they're gone. But if you saw a client for a full semester, they're a part of your life now.
Okay, so thank you everyone for listening. Please tune in to our last episode of the season next week. We'll be doing an Instagram poll to decide on what our last episode, what the topic should be. So please just tune in and look at our Instagram to make sure that you can vote and help us out.
We want to do what you want to do, so we go out on a good bang. So speaking of Instagram and social media, why don't you follow us? You should follow us on Instagram. We're SLPeasinapod, as well as our individual accounts. We have Arva T SLP, Gracie Z SLP, and Yuritsa SLP. We are now on iTunes and Spotify. And you can always watch us on YouTube if you miss our beautiful faces.
Thank you so much for watching, and we hope you're having a good day or good night wherever you are. Thanks for joining us in the pod.
Bye.
Bye.